welcome to our series of IUFRS conference. We had 6 conferences in 2023, and thank you for all of you that were part of it. And we are having the first seminar of the year with Professor Manning. Also, a master's student and PhD student can get credit. Please remember to sign the sheet, and then through the transfer de connaissance and seminar de doctorant, you can get the credit for your participation as well. So Professor Manning, MBE, he's a clinical academic children's nurse with a strong national and international profile within the field of nursing, pediatric critical care, and clinical academic capacity and capacity development. He's a professor of nursing and child health in a School of Healthcare at the University of Leicester, and Nottingham Children's Hospital in UK. Joseph Manning leads a methodological diverse research with a mission to improve the experience, outcomes, and lives of children, young people, and their families. He has also received more than £8 million in competitive grant capture from national and international funders. And currently, he is a chief investigator of the NIHR-funded UK National Oceanic Study. He is also a co-investigator of North American PICS-P study, Singapore SHAC study, and our own Swiss PICS-PF study. Welcome.
Thank you very much, and it's a great honour to be invited, so thank you so much for inviting me. I'm really delighted to be back. I was in Lausanne just over 14 months ago, here presenting at the Swiss Society for Early Childhood Research. So it's great to be back and be with you and to be delivering this seminar. So I'm going to talk over the next probably 30 minutes around how we as a critical mass of health professionals can start to revolutionise healthcare through cultivating a culture of innovation and research within the clinical settings that we work in. Just to disclose that I'm currently in receipt of funding from our national funder in the UK. So whatever views are expressed during this presentation are my own and not that of the National Institute for Health and Care Research or the Department of Health and Social Care. So during this presentation, what I really want to do is provide and really reflect on the context in which we're delivering healthcare. That has changed quite substantially over the last 3 to 4 years and will continue to evolve. So I think really understanding the context in which we're trying to revolutionise is important, and then bring some of my experiences and insights as somebody who's working within an academic setting, but also within a clinical setting, in a direct patient care role, but also in a leadership role, and think about how we across our contexts and within our contexts can really mobilise the ambition and mission as to why we need to have cultural change and why we need to really embed research and innovation in everything that we do. Think about the activities in which we need to do that, and reflect on how we will know whether we've achieved that through the impact. And I'm going to just briefly talk about an example that some of my colleagues are leading within my hospital around in the innovation space, which I think is going to be hugely impactful. So I hope that's okay, and we're going to have some time for questions. If I'm speaking too fast or if something is not clear, then please do let me know, wave your hands, start yelling at me. And it's great also to see so many people online joining us. So hopefully it will be interesting and we'll have some good discussion. So I think universally, there is a constant change to how we organise and deliver care. And certainly in the UK context, we are shifting to an integrated care system approach to the commissioning of services and the organisation of delivering those services. And there's a real sort of ambition to ensure that services align to population health needs. And so that these integrated care systems are clearly embedded within local organisations, and ensure that we have clear partnership between health, social care, third sector to meet those needs of quite diverse needs of populations. And that may be different. It's different in the US system. It may be different in Switzerland. But what we're all experiencing in respect to how our systems are coordinating and delivering services is that we're feeling the fallout of the COVID-19 pandemic. Workforce is in crisis globally. We know that we have real deficits in our workforce numbers, and it's really challenging to recruit and retain staff. And that's not just unique to single professional groups such as nurses, but it's universal across all healthcare professionals. The other thing to note is, and I think became really illuminated during the global pandemic, was that we're not treating single systems. We have populations that have multiple morbidities or chronic, complex, long-term conditions. And so conventionally, how we have developed and treated or addressed the needs of certain groups of patients are not how we need to support and meet their needs, because the needs are far more complex. They may transcend different organ systems. They may transcend health. And I think we're more aware of the social determinants of health more than ever. COVID definitely shone a spotlight on some of the health inequalities that exist, and they manifest going forward into this new and ever-changing healthcare landscape that we're working, living, and also are the receivers of healthcare within. And then certainly within a UK context, but I think again, globally, there is economic challenge. There's geopolitical posturing that is affecting supply of food, access to finances, and that has an impact on people's health and well-being, certainly emotional health and well-being. But it's something that we need to also be considering as part of the context in which we're providing health and care going forward. So I can speak in relation to my context, which is in England. We have a nationally coordinated and delivered healthcare system, but there is clear mandate that to ensure that we can meet population health needs, we need relevant and high quality applied health research. We need the discovery science that needs to happen, because that's where bench innovation occurs, but also we need to think about how that can be implemented and applied within health to inform clinical transformation. And so there is a clear steer nationally, and I think that's comparable across certainly Europe, that we to meet the challenges that we're facing today and of the future, that we need a robust evidence base, and we need to ensure that that applied healthcare space aligns to population health needs, and that we forecast and predict where that goes in the future. Innovation is also aligned to that. So innovation is where we can try and drive the clinical transformation and work in different ways to meet the diverse needs. And there's a clear mandate. In addition to developing the evidence base, we have to be innovating, and there's much advancement with regards to digital and technology innovation, how and when we deliver services, and whether the convention needs to be challenged through using an innovative lens. So I think the contemporary landscape is very clear that research and innovation needs to be central if we are going to meet the needs of not just the population health of today, but also of the future. More closely aligned to our practice as health professionals delivering clinical care is that we do often have a divide between our clinical insights and priorities and the research and innovation that is done. And so we need to be clear that it's not just about developing the evidence base or thinking more innovatively and working with industry and technology partners to drive the innovation pipeline, but also it's about all these other things that should align to our practice. There's clinical excellence, inquiry, having that inquisitive, critical thinking mind and thinking of where the opportunities are within our practice to innovate and to mobilize the evidence base. Innovation is there, so we need to be thinking innovatively. And I think oftentimes we are innovating in real time. You know, oftentimes we don't have enough staff to, you know, meet all of the patient's needs. So we innovate, we think of different ways of working on that shift to ensure that all of those patients are safe and receiving a good quality care. But also every nurse or health professional is a leader when it comes to patient care. And so it's about how do we employ and mobilize our transformational leadership so that we can really bridge those clinical insights and priorities as identified by us as health professionals, but also by our patients and families with the evidence base in either driving it forward and, you know, directing that evidence base or the implementation of that within clinical care. So that's the wider context, and I think it's really important that we reflect on that and keep that insight when we're trying to develop a culture, because ultimately that will give us some steerage as to where that culture needs to be, and also what is on the horizon with regards to any changes within the wider healthcare landscape. But creating a culture is very dependent upon context. And whilst we looked at wider context, we also need to be thinking about local context. And that context is absolutely king. Any implementation scientists within the room will understand that we really need to have a robust understanding of the context in which we're trying to change the culture. And that will be affected by your role within that context, the population that you serve and their specific needs, the organisational mission and vision, what health system you work within and your organisation interfaces with, and also your geographical region. So all of those are really important. And for me, as I say, I work in the UK, and we've got some clear drivers nationally around ambitions in transforming our workforce and in transforming the healthcare space so that innovation and research happens. It's core business as well as the delivery of high quality, safe, effective and efficient clinical care. And so a number of years ago, you know, it's 2012, there was a clear steer from the government that we needed to have professionals, not just doctors or dentists, but also other professional groups that had what we define as a clinical academic career, but it's where they have engage concurrently in clinical practice and research, where they provide research leadership and they innovate, have scholarly activity, and also drive the pipeline of evidence-based healthcare. On the back of that, this is our most senior Chief Nursing Officer, Professor Dame Ruth May, who sort of really confirmed the value that clinical academics have in not just generating science, but also improving the health outcomes of people and their experiences, but being really pivotal in that interface between the science and practice and bridging the oftentimes difficult divide that manifests. So it's really good that we've got some national steerage and some real impetus and drive to make redevelop the workforce so that we have people in practice that are really ambitious and driving that culture around research and innovation. And on the back of that, we've got a number of bits of research that are coming out that really identify and articulate the value added components of having clinical academic careers for health and care professionals. And culture is in there, as well as, you know, really driving forward that clinical transformation that's needed at pace and scale. The other thing that's happening nationally is around an ambition from our national funder in a focus for health outcomes. And they've got a framework that's just been launched around this sort of 4 pillars in which they're assessing whether the investment in research is having the desired impact. This is around addressing population health needs, but it's not just health, it's also about addressing the wealth issue. And so ensuring that we are doing research that not just addresses health problems, but also has economic benefit. And I think oftentimes we don't always consider that at the front and centre of our decision making. We want to address the needs of the patients and families that we serve, but also we need to be thinking about what is the cost implications, whether it's a cost benefit or whether it's actually going to be a cost savings, more efficient to do it in that way. They're also absolutely focused on productive partnerships, and that's working with industry and other sectors to really drive forward the evidence base. And they want effective research. So it's not just, you know, the sort of research that needs to be done that will sit on a shelf, but actually something that's really going to drive the clinical transformation that's required. And on the back of that, we also have Dame Ruth May's office. There's 2 professors, Professor Cooper and Professor Richardson, that have identified a research plan. So this is specifically for nursing, but there are an allied health professional plan and also one for medical careers. But really thinking about what do we need to do to enable the strategic mission to be delivered. And whilst a number of those points are around research, it's also about cultivating a really good nurturing environment to enable people to be developed, and also ensuring that they have the adequate sort of technology and are digitally enabled to do that. So that's the sort of the macro outline, and we have career pathways, really defined career pathways for all health and care professionals that allows them to develop not just the clinical profile and credibility, but also the academic training that's required them to be high functioning, impactful clinical academics within the health and care system. So locally to me, this is the Children's Hospital that I work in. I still continue to practice as a critical care outreach nurse, but I also work in a leadership role, supporting the development of research and really sort of ensuring that we've got research and innovation as part of our core activity within the Children's Hospital. So we have it's based in Nottingham, and I don't know whether you know this figure, Robin Hood. Yeah, so synonymous with Nottingham, Sherwood Forest. And whilst it's a relatively small inpatient bed base, it provides a wide variety of specialised and super specialised services. We have an intensive care unit, we have a very large neonatal unit, and we're providing services regionally and super regionally. And so that is a hotbed for lots of patient needs that are very diverse, and that we need quite a robust evidence base and quite a lot of evidence to really inform how we transform and ensure that those services that we're providing align and meet the needs of those populations. So I'm going to talk a bit about mission, activity and impact. And I think some of the work that we've done in building a culture of research and innovation started with mobilizing the collective voice. And we've done that through extensive consultation with the whole multidisciplinary team to ensure that we are aligned to why do they do what they do. And I think, you know, oftentimes we sit in our silos of practice. We sit in, oh, well, I'm the PICU nurse and you're the oncology nurse and we are very different. We look for the difference. But actually, when you try and mobilize collective voice for collective action, it's about saying, well, how are we the same? What values, mission do we share? And that has been really useful in trying to come up with a unifying statement or vision for our children's hospital that we all align to, because then we can say, well, we're doing this because we all ascribe, align, uphold this mission. And that is to provide the highest quality relationship-centered care and outcomes to neonates, children and young people. And I'm sure anybody working in children's probably relate to this mission. We could just replace Nottingham Children's Hospital with your hospital logo, and it would probably align to that. But I think the process in doing, mobilising the collective voice and co-creating that mission is really important because we're all signed up to it through that activity. I'm just going to briefly talk about some of the science behind this, and it's just one slide, but I think this normalization process theory is a framework in which you can develop and evaluate and implement complex interventions, but we used it as a framework or a process for how we came together and implemented the activities on the back of this mission. And so there is a sort of 4 stages. It seems a relatively linear, and I think our application of it certainly wasn't linear, but there's the first stage is trying to get coherence. So through that, mobilizing the collective voice of the workforce, what is it that we're doing? What are we trying to do? And on the back of that coherence work, we also establish some clear objectives to understand what was the work that we were doing. Then it was cognitive participation, so establishing who is going to do the work. Where does that work sit? And I think oftentimes we've conceptualized research and innovation as somebody else's business, and it's certainly not conventionally been nurses' business. But that othering is we really tried to challenge that, and that was a really useful, although protracted process, but it enabled us to start to shift hearts and minds of culture and what they perceived to be the expectation and what was the expectation. So, and then it goes to collective action. So about how do we mobilize this strategic plan? And then how do we know when we've mobilized it? What's the impact, and that reflexive monitoring? And I think this framework has great utility in applied health because it's been developed for the purpose of applied health, for the complex phenomena, intervention and context that we work in. So that's the theory bit out of the way. So some of the strategic objectives, and I've specifically put nurses here, but it was about all practice was, you know, we absolutely aligned to the fact that this wasn't othering. If we wanted to change the culture of research and innovation across our hospital, then we needed to make it everybody's business. And then we had some more detailed about activity. You know, we wanted to develop and implement new knowledge and innovation to really advance the care that we were providing to our populations. And then I think something that we don't do very well is celebrate it. You know, celebrate and promote what our contribution has been. We love to share the findings because there's currency in it in doing publications, but actually different approaches. How do we communicate it to our teams, who often feedback and say, well, I didn't even know we were doing this piece of research. So we have to tackle that, and that's a work in progress, but it's something core as part of our mission and objectives in trying to develop a culture of research and innovation. I think the other thing to say is that it didn't just happen. We had to get senior buy-in and had to really align to the strategic intent of the organisation. When you're trying to implement change, it's really difficult to do that if it doesn't, the planets don't align. And so it was about our university partnerships, working with our hospital, wider NHS system, and really thinking about, okay, well, where does this sit with their wider strategic plans or strategies? How can we forecast where that goes in the future? And what were their priorities, and how could we align them with that? Because I think that's a strategic way in which we can try and address multiple ambitions and agendas and work really smartly. So that was a really important thing to help start changing the culture. And then the other thing was around core business. So as we talked about, using the normalization process theory and getting that sort of coherence and sense making process, but also thinking about where does this fit in the bigger picture. And these were our ambitions for research and innovation, but they sat within a wider strategic plan. So there were a domain of one of 4 domains. So the other domains were leadership at all levels, inclusive talent management and lifelong learning, and pride, recognition and reward. And research innovation was the 4th domain. And collectively, if we got all of those right, we could have the highest quality relationship-centered care for our neonates, children and young people, as well as an absolutely awesome culture and workforce that were not just research aware, but actually driving forward research and innovation across all of our clinical services. So we've talked about the why. The other thing was around trying to prioritise and get some defined activities. So this was sort of driven by the national drivers, and we've talked about some of those national drivers that existed. There was also some steerage around clinical services and the transformation for children and young people services, and a really significant document around how we are planning for the future called the NHS Long-Term Plan. And that really gave us some steer as to where our sort of cross-cutting focus should be. And the work that we were doing around research and innovation, where our ambitions lied, should really be focused on clinical impact. You know, that's why we were there, why we were doing what we were doing, was that it should have some relevance to driving forward the quality, the safety, the efficiency, the experience or effectiveness of care at some level. And we knew that we couldn't do this in isolation, so we had to recognise the wider digital agenda, and there was significant work going on around digital and technology interface, but also working in partnership with our key stakeholders. So it was around using creative, participatory and rigorous approaches to engage and to work with and do research with our children, young people, their parents and families. And then from that, we identified 3 main programs or themes of research, which I'm sure, I hope, will resonate with you. So the first theme is around harm-free care. And this has, you know, really key priorities around some of our inpatient challenges, sensitive metrics around skin integrity, medication errors, patient deterioration, and we're seeing growing numbers of children and young people come through our care in mental health crisis. So we need to focus our work in that space. We also recognised that there was some key issues around supporting health transitions. So that could be transitions of care across a care pathway, it could be transitions in clinical status, or it could be transitions in decision making. And we've had a number of high profile cases in the UK around where decision making, where communication hasn't gone optimally, where differences in opinion and viewpoint have caused conflict, resulted in conflict, and have been escalated. And so we've focused a key theme around supporting health transitions in its most broadest sense. And then finally, a focus around optimising long-term health outcomes, because conventionally where we've focused our attention has been on my silo of practice. So they come into the PICU, I'm really interested what happens whilst they're on the ICU, and then they leave and get step down to another clinical area, and I'm not that bothered. You know, that's not my priority. Well, it is your priority now, because we're focused on health care pathways. And so absolutely we need to be cognizant of what are the long-term outcomes, what's the impact of our care, and where do we need to align some of the resource and services to support, rehabilitate these children and young people so they have the best possible outcomes and least impact on lifelong consequences or sequelae. So I'm just going to give you a brief example of some of the research and innovation that we're doing in the harm-free care space. And this relates to recognition and rescue. Two of my colleagues, Nikki Taylor, who's our critical care outreach strategic lead, and Dr. Takawara Marufu, who's a clinical academic nursing research lead, has led some of the work in this space. And we have a systems approach based on research and innovation that's happened over the past decade and a half to ensure that we have adequate mechanisms to recognise and rescue deterioration in children. And the impact of that, and this was a paper that we published in Nursing and Critical Care back in 2021, but showed a significant drop from just under 25% failure to rescue rate right down to what we're oscillating between now is 0 and 3%. Okay, so we've become more sophisticated because of the evidence-informed interventions that are driving the innovation in clinical practice, such as an electronic observation system that has automated escalations within it. So it, you know, if you trigger on the early warning score, it will automate to the critical care nurse or to the physician. As well as mock arrest program, resuscitation education, and building into the electronic observations, running in the background a sepsis screening tool that will trigger and prompt you if they fulfill that criteria. But what we recognised is that we weren't finished yet. And we started some work actually before Martha's Rule came into play or became on the agenda. And this was funded by Oracle Cerner, which is probably one of the largest EPR companies in the world, and also the ANCC Pathway to Excellence group. They funded the development of an app for family activation of rapid response systems. And that's because we recognise within our system, whilst the nurse at the bedside would be doing the assessment, putting in the numbers, escalating, they could ask the parent, but there were barriers to that. And we serve a proportion of our population are non-English speaking. And so verbal communication may be a barrier to actively engaging parents to activate the rapid response system. So Martha's Rule, I don't know whether you've seen Martha's ruling. So this was her daughter was admitted to a hospital in the UK and tragically died. despite her concerns not being escalated. It was due to her concerns not being escalated. And so there is a rule that's going to come into practice that every child will have access to a second opinion when they're in hospital. So every family can request a second opinion. How that is operationalized, we don't know yet, but we feel that our technology may be a solution, part of the solution to this. So we developed through a systematic review of the literature, mapping context, mechanism and outcomes to try and understand the content for an app. And then we used experience-based co-design as a method to co-produce with parents and families. We went out into the community. A lot of them the purpose of it was multilingual, and we co-produced an app. So this is an app that I will just click the button because I think it starts to play. So you'll see on the left-hand side of the screen is the English version of the app in what the parents would see, sorry. In the middle screen is the Urdu version of the app, because that's one of our second most prevalent languages in Nottingham. And then the final screen is what the nurse, the critical care outreach nurse, will see. So there's an interaction that happens where parents can escalate, answer a number of questions, and escalate to the paediatric critical care outreach nurse, who will then be able to either respond and say, please speak to the nurse in charge, or I'll come down and assess you immediately. But it's just another conduit, a vehicle in which we can try and allow our families, the diverse populations that we serve, opportunity to communicate and escalate their concerns. So that's just an example of some of the innovation that we're doing within the Children's Hospital, and contributing to this culture of research and innovation. So in addition to that, people are an organisation, and so we're really committed to developing our clinical academic workforce right through our pre-doctoral level, our doctoral level, and postdoctoral level. And I think, having a good pipeline, having open and accessible opportunities for staff to be developed, to have access to upskilling, and also access to funding is really important. And I think we've been quite successful in generating and supporting individuals to pursue clinical academic careers throughout the pipeline. We also have some wider activities, and I think this is how you can really infiltrate the culture, is by bringing research and innovation to the fore at every opportunity. So we have an evidence-based practice council, specifically for paediatrics and neonates, where all clinical guidelines are developed, reviewed, and ratified within that process, within that council. And that council is composed of lots of different nurses and clinicians and professionals, where they come together and through their collective voice start to ensure that ensure that we've got an adequate evidence base that is of quality to inform our clinical practice. And then there's training to undertake that activity, but also there's quite a lot of quality improvement activity that feeds into the research pipeline. So we oftentimes do a lot of quality improvement stuff, and that sort of, certainly within the harm-free care domain of our programme of work, informs subsequent research. And then we have a number of offers for direct care nurses. So we have something called the Chief Nurse Excellence in Care Fellowship Programme, and this is an opportunity for direct frontline nurses to do a quality improvement project or have some exposure to research and innovation, but also to develop their leadership skills. So they'll have exposure, mentoring from the chief nurse, which is really illuminating, as well as senior executive, to understand, you know, what are the challenges that you face? What advice would you give an aspiring, developing clinical academic nurse or a nurse leader of the future? And so that's a really good scheme, and we've been running that for a number of years now. Okay. We also have mentorship and coaching available, and we support a lot of the applications to the funded programs that are happening regionally or nationally. So what's the impact? Well, we've had quite a lot of impact. We've had a lot of people being developed. We've had a lot of activity. We've had a lot of income as a result of generating a culture of research and innovation. And I think, you know, that continues to grow as we go forward in our journey. So I think just the final bit of my presentation, I just wanted to offer some reflections on how we, as working in different contexts, can try and revolutionize healthcare through research and innovation. So I think people are absolutely integral. You know, leadership is relational, and so it's important that you get the right influencers and enablers around the table, and to also be around the table yourself. So ensure that you've got that and you're sighted of who is going to be influential and who's going to enable you, and also who's going to be a barrier, because I think oftentimes it's useful to address those people head on, to understand they can bring some real sense to the table. You know, if we surround ourselves by enablers, then we will only see a unidimensional perspective. And so having the naysayers or the haters in some situations with you and really try and understand what is behind their thinking and why they're so against certain things can give you insight and opportunity to address those issues. But there's a whole raft of other people that are enablers, and everyone in this room is an enabler to culture change. As parts of the team, as managers, we can make or break people, we can make or break the culture, and so it's important that we are unified. We may differ in opinion, but we're unified in our mission, and hold people to account to that mission. If we've had mobilize the collective voice to agree that why statement, why are we doing what we do? Because we want to provide high quality care, right? Well, we need all of those 4 domains satisfied, and we need to be on board with this. But there's other things that are also enablers, and so having funding, having patient voice with you is really important, and has been a great enabler for us, because actually listening to the voices of patients and saying, actually, this isn't high quality care. I've had a really bad experience. It was very unsafe. I didn't feel cared for. I wasn't supported during that transition. My long-term outcome has been impacted. That gives you clear clarity over what you should be doing around your strategic mission and those activities behind that. I think we need to be shifting our thinking, and oftentimes we think very sort of simplistically, and you know, I'm also very guilty of this, but we need to be thinking more systems wide. We have integrated care systems, and we're thinking, you know, joining up those dots and thinking unconventionally as to how we can work with different people, and try and identify solutions. And part of that is knowledge exchange. So creating a culture of research and innovation is about, well, let's share it. You're probably working in a different space to I'm working, but actually you've probably got the solution to my problem. But if we don't communicate that, if we don't exchange that knowledge, if we don't have mechanisms and process to do that, then we still will work in our own little silos. The other thing is, on that same vein, is around team science. And whilst I'm a proud nurse, and I am absolutely, it's a privilege to be a registered children's nurse, I recognise that I will have a view of the world, but we're better together. And so we need to partner with experts across sectors, disciplines. Certainly in the innovation space, I'm not an expert on intellectual property. I'm not an expert on implementation and stakeholder mapping and understanding the commercialization pathway. But as part of my teams, I have people with that expertise and insight. And so we do need to look for people to come in and come on the journey with us, because we're absolutely wedded to the team science approach, and that will make our science better, and it will also make our innovation much better. We need to be working across the framework of research. So a lot of the work, because of the state of the science, may be in the theorizing or exploring stage, but we do need to shift all of our work together into the long-term implementation stage. And I know this framework has been redeveloped and redefined, where implementation is seen at the outset. So we need to be thinking about that whilst we're generating our science. But irrespective of whatever you're doing, it's about maximizing the impact from that activity and ensuring that every opportunity there is impact to either inform or enhance patient care and patient outcomes. And the final thought is think the unthinkable with regard to research and innovation. And nowhere did we think that we would be at this point in our journey of development as a children's hospital. We didn't think we would have an app that we're now speaking to policymakers at NHS England as to how potentially that could be used or implemented within wider NHS context. So really think the unthinkable and challenge yourselves and challenge each other to think the unthinkable, because great things may happen. So I think just to conclude, creating and cultivating a research and innovation culture does take time. It should mobilize the collective voice. And I think every time I am challenged by something or someone, I come back to, well, what is our joint mission here? And I think that really cuts the noise around individuals or agendas and comes back to the value of what we're doing. And that's around providing the best patient experience, care, quality, safety that we can. So I think the why you're doing what you do, certainly within the research and innovation space, is really important to bottom out. And as I say, we often look for the difference, and it's our opportunity to bring the linkage and the commonality. Creating the culture starts with everybody, and we've all got an opportunity today to do that. But we also need to bring people with us, and it's about the people, it's about the activity, and it's the environment. And that will start to generate a movement in this space. So be inspired and really change hearts and minds, because we need that for healthcare of the day, today, and also for the future. Thank you very much.